and Affordable Care Act. And one of the outcomes of that ACA was the development of the Patient-Centered Outcomes Research Institute, or also known as PCORI. Now, PCORI is really emphasizing patient-centricity. It is a nonprofit, government-sponsored organization, which is truly charged with supporting comparative effectiveness research to assist consumers, clinicians, purchasers, manufacturers, and policymakers in making informed decisions with the intent of then improving healthcare as a whole. Now, in 2021, the patient or PCORI outlined their new national priorities. So what they did was a bottom-up approach where they queried their community, patients, family members, other people, really outlining what should be the focus areas of PCORI moving on forward. And those are outlined right here, as you can see in this image. So they're very much focused on achieving health equity. They want to accelerate and progress towards integrated learning health systems. So really advancing the way our systems develop and learn and provide better treatments for all. They also want to increase the evidence for existing interventions and emerging innovations in healthcare. They also want to focus to enhance the infrastructure to accelerate patient-centered outcomes research and advance the science of dissemination, implementation, and health communication. So all of this is really centered around patient health, and they are centered around improving the overall quality life of people. So this is, again, a wonderful institution that's really driving our research forward. They have outlined a lot of funding opportunities for those out there that are interested in more research as well. So then patient centricity, and what does that actually mean for our bleeding disorders, and how is this important for bleeding disorders, and how are we talking about this a little bit more? So patient centricity is systematically embedded through integrated care models. So integrated care models are really those that are capable of placing the patient in the center and utilizing different resources to really provide integrated care. So within the bleeding disorders, those that are really most equipped for providing integrated care are our hemophilia treatment centers. So there we have an interdisciplinary core team. So as many of you know, you have now only access to a well-qualified and specialized hematologist, but there's also a social worker, a physical therapist, a nurse, and access to a specialized coagulation lab. So that really encompasses the interdisciplinary core team. All of these individuals are specifically trained and have special expertise in coagulation situations. So they're really well equipped for providing a high level of care. Now, the other part are extended external team members. So within an HTC setting, you might have access to your interdisciplinary core team, but then also that team can pull in additional external team members. So some of examples would be an orthopedic surgeon who might perform a knee replacement or other surgeries throughout. You might also be able to pull in a genetic counselor. Often they are part of that entire team, or they might be a referral source away. So if somebody is looking towards increasing their family, becoming pregnant, having a child, a genetic counselor would be a wonderful resource to have. Other people could include a pain specialist, might come in for a specific pain clinic, or an OBGYN, again, looking into that reproductive health component where we might be pulling in an OBGYN to really team tag with the hematologist and the team to assure a healthy pregnancy and delivery. So there are all these wonderful extended external team members that are not part of the core team, but that work very closely with the HTC together. So with all of this, again, we are putting the patient in the center and making sure that the patient receives all the different components of treatment to really enhance their quality of life. There was a recent wonderful article that talked a lot more about integrated hemophilia care. So obviously this plays also a big role in other bleeding disorders, not just hemophilia, because again, we have those specialists available there. So in this article, they also talked about the general model of cost reduction. And this is where patient centricity becomes important too. And as you've heard from the triple aim, it is essential to really reduce the healthcare costs. And we do know that by providing integrated care and utilizing integrated care models, we can actually decrease the total cost of care because we are so specialized and we're able to provide a lot of the essential services there. So this is really how we can integrate patient centricity into our bleeding disorders world and how it opens the door for us to provide this a little bit more. So how does shared decision making then play into this? So shared decision making is the big buzzword. And again, it's not new. So shared decision making is not something that very recently came on the market and is this new concept. Shared decision making has been around probably for as long as patient centricity and the concept of patient centricity. However, we recently started talking more about shared decision making and the need to further diverge into this, learn more about it, and integrate it really into our day-to-day practice. So it's kind of getting a little bit of a revive lately. And there are some specific reasons of why this is happening right now in our bleeding disorder world. So let's talk a little bit more about shared decision-making and how it fits in within that big concept of patient centricity. So a little bit of history and a little bit of review of how we actually got here and got to that point of shared decision-making. So prior to the 1980s, so a little bit of a while ago, we really had that paternalistic decision-making model. This was really the standard. So what that means is that in a relationship between the patient and the physician was the dominant role who would make all decisions for the patient. And that was truly built on a couple of assumptions. So for example, for most illnesses, a single best treatment exists. So what's the assumption that no matter what disease it is, there's no layer of complexity. There's just one treatment, and that one treatment is the very best treatment for that particular situation. Nowadays, we obviously know that treatment is a lot more complex than that. Now, another assumption was that physicians know about the best treatment available and consistently implement this as well. So we also know that that is not always the case today. Now, physicians are in the best position to evaluate risks and benefits and to make a treatment decision. Sorry for the little typo there. So again, that was one of the assumptions that was there. Another assumption was that physicians have a legitimate investment into the treatment decision due to their concern for the patient's well-being. So these were really the foundational assumptions that allowed paternalistic decision-making, where really the physician is the driving force in obtaining information and then deciding what the best treatment options would be. Now, another component that needs to be put into that entire model of paternalistic decision-making are the differences in education, income, and gender, which are often contributors to the power differential between the patient and the physician. So often in this model, a shared decision-making process was not possible in that entire situation of different backgrounds and different values didn't really play into that. So moving forward in the history. So since the 1980s, all of that has become to be more questionable. So the credibility of these assumptions began to be questioned by many, many people. And at the same time, we started to increase the research. Now, research started to truly then focus on more effectiveness studies. They also looked into the appropriateness of the service deliveries and really healthcare as a whole. So what they found is, A, that healthcare costs and the quality are of concern. So we all are very well aware that our healthcare costs are ever rising. So that was also the case in the 1980s and since. So since then, we've really started to look more into this. But then also quality. So what they found in a lot of those research studies is that while a patient in area A might have exactly the same disease as a patient in area B, they might receive completely different treatments. And there might be that thought that maybe the patient preference might be the direction there or might have led to that. But what they actually found out is that not everybody is always aware of what the best treatment options really is. And sometimes the thought process of whether or not that really is the best treatment option was also different between different physicians. So they had their own opinions and their own biases to different treatments that would then direct the patient care. So they found out that quality isn't always the same, and not everybody is following each and every recommendation and guideline to a T. So there were a lot of differences. The other part that really happened during this time is that there was some legislation passed to really safeguard the patient's rights And what this legislation said that is that every patient has a right to being informed about all of the available treatment options. So with this, that really opened the doors then for shared decision making, because in that very moment, it is no longer a physician in a dominant role who will just decide on whatever the best treatment option is, because in that moment, it is more important to inform the patient about, well, here are all the treatment options, and really bringing the patient in. And that opened the door to elevating the patient as a partner in the decision-making process. So from this, there's two other models that really we're developing. One is the informed decision-making model, and the other one is a shared decision-making model. So I'll talk a little bit more about these in the next slide. So let's unpack these a little bit more. So we talked a lot about the paternalistic decision-making model. And again, this paternalistic model has a one-way information flow. It is really just from the physician to the patient. And the information that is being provided is purely centered around medical information. It is the physician alone who's doing the deliberation, and the physician alone who makes a treatment decision. So we've talked about the paternalistic one. Then, as I've said, like two other models have really merged out of the changes that started to happen in the 80s and still continue to this day. So one was the informed decision-making model. So in this very way, we still have a one-way information flow, and it is again from the physician to the patient. But what the physician is providing in this moment in time is medical information about all the different options. So they are giving the patient all the different information that is out there, and then it's up to the patient to deliberate on these different information pieces and to make the decision on what treatment they want. So it's essentially the physician giving all the information, the patient taking in the information, and then making their own decision on what treatment they would like to accomplish or what path they would like to take. Now, from there, the next step is then really the shared decision-making model, and this is what we're talking about a lot more today. This has really a two-way information flow. So the information is given from the physician to the patient and from the patient to the physician. So the big difference here is that we are having information that is medical as well as personal. In this very model, a physician might be sharing all of the medical information, different information about the different options that are there, about the risks and benefits of each of the option, about the current research and other details that are needed. But at the same time, the patient is now able to share a lot of their own values and preferences and what really matters to them. Because what matters to them and what is important to a patient might be very different to a physician. But it is important to acknowledge these in a shared decision-making process. So again, in that very moment, it is both the physician and the patient who are deliberating about the best path forward. The other part to this is that the patient might be additionally influenced or pull in other people that are important to them. For example, family members, spouses, partners, friends, other people they trust. So especially when big decisions have to be made that are really influential on the treatment and the potential outcomes, many people like to pull in additional people to really then deliberate about the different options and coming up with a best way forward for them. So in the end, the treatment decision is not made by the patient or the physician, but by both of them. So the patient is elevated to a true partnership with the physician and deciding on what the best option is for them. So we've made big strides from where we started. So just to define this again of what shared decision-making truly is, well, shared decision-making is a key component of patient-centered healthcare. It is a process in which clinicians and patients work together to make decisions and select tests, treatments, and care plans based on clinical evidence that balances risks and expected outcomes with patient preferences and values. So it is not just based on all of the medical data and information and risks and benefits, but it truly includes what matters most to the patient themselves. Let's unpack this a little bit more. So some of the benefits of shared decision-making is that it truly builds a trusting and lasting relationship between the patient and the healthcare providers, which is something that is so beneficial to us in the bleeding disorders world where we have a continuity of care. So it's important for us to build these trusting and lasting relationships so that we can be most effective. So other benefits from the patient lens are really an improved experience of care and an improved adherence to treatment outcomes. Again, really important to our bleeding disorders world, where we are always talking about adherence to treatment protocols. So by building a shared decision-making process into our day-to-day standard care, that can really aid in improving adherence to treatment outcomes. Now, from a healthcare provider lens, it truly improves the quality of care delivery as well as patient satisfaction. I know many healthcare providers are always hammered with these patient satisfaction outcomes and so forth. So this is really a way of improving those. Now, it is currently not clear if shared decision making clearly impacts outcomes, so patient-related outcomes in regards to their disease. So we don't really have any good research data on that. However, it has been established that the quality of care and satisfaction are really the driving forces behind the shared decision-making process, and we do have research to support these. Now, who's actually involved in this shared decision-making process? Well, at the center are truly the patient and the healthcare provider. So those are the most active participants in the entire process. Now, the healthcare provider initiates the conversation by truly informing the patient that they will have to make a decision and a choice, and involving them throughout the decision-making process. Now, they might provide different options, describe risks and benefits, and any other details about the different options. But then the patient is also involved by truly providing, again, their values and their preferences. So they are kind of at the center of this entire model. However, both of them are kind of coming from different lenses, and they might ask different questions or have different concerns or questions that they would be asking. So from a healthcare provider lens, they might be more concerned of, will this be safe for my patient? Will this actually alleviate any of the symptoms that they are describing? Is this going to cause any issues in the future? Or how will my patient gain access to the treatment itself? Do they know and understand all of the risks and benefits? That's kind of more from the provider lens, and there's probably many more questions that are going through the mind there. But looking at the patient lens, those questions might more center around, will my insurance pay for this? Is my healthcare provider listening to me? Am I happy with the treatment plan? And does this treatment plan actually work for me and my lifestyle and what I want to gain from this? And do I need to miss work, school? How will this impact my life as a general? So there might be little different questions here. So they come both from different lenses, and it's important to understand this. Now, there's other people involved in this as well. So we talked about the patient and the healthcare provider really truly being at the center. But as I mentioned before, often in especially the deliberation process, there might be additional people involved to support the patient, especially when we're talking about big decisions. So it might be a family member, caregiver, friends, other people that are in the immediate network of the patient. Might also be a decision coach. So some healthcare facilities actually have decision coaches. It might be a social worker, a nurse, it might also be a health educator who come and sit down with the patient and truly make sure that they are clear about what the healthcare provider told them, and really talk them also through the values and preferences, and really try and help the patient find those and identify what is important to them. Might also be additional support staff who might really have an overview of different shared decision-making aids, and who really assures that the decision-making process is integrated into the clinical setting. Lastly, there's also a medical treatment specialist. So that person might really influence both the healthcare provider and the patient. So there might be a specialist who's providing a specific treatment who now needs to communicate with both of them. For example, in the bleeding disorder world, maybe a medical treatment specialist would be an orthopedic surgeon that is pulled into the conversation as well to provide additional treatment options. So all of these together are really kind of that core of the decision-making process and the main people that are involved. Now, is the patient influenced by additional information that they are gaining from, example, the World Wide Web, social media, and so forth? Absolutely. Is their culture and their general background driving this? Absolutely. So those are additional components that will influence the patient as well. Now, how can we actually go about integrating shared decision-making into our day-to-day clinic? Well, there's a couple of different models that were proposed of really providing a framework of how to integrate this into your clinical setting, and how to really make this more approachable and give it kind of a roadmap of how we go about this. Now, one of these is the share approach. And I really personally like the share approach. It's very systematic. It's a step-by-step process of really engaging the patient into the conversation and allowing the patient, again, to become a true partner. This is also something that is really pushed forward by our Department of Health Equity, as health quality improvement as well. So let's talk about the share approach. So the share approach really starts out with seeking participation. It moves into helping to explore and compare options. A stands for assess values and preferences. R stands for reach a decision. And E is to evaluate that decision. So share, seek, help, assess, reach, evaluate. So let's talk about each and every one of these a little bit more in detail. So again, the first one is seek. So in this very moment, it's to seek patient participation. No shared decision-making process can start without both parties knowing that there actually needs to be a decision made about different choices. So it's all centered around a clear communication about the existence of a choice. So, for example, in the bleeding disorder community, we might have to make a choice between different treatment products or different treatment options. Now, the second part is really an invitation of the patient to be part in that decision, to be involved in that decision-making process. It is one thing to communicate that, hey, we need to make a decision on these different options. It is a different part of really inviting the patient to the table and, again, elevating that patient as a partner and allowing them to understand that you matter, your values and preferences matter. You matter in this decision-making process. So it's really important to clarify that. But there's a couple of food of thoughts, and these also kind of build the boundaries of shared decision-making. So one, patients have a right to understand their treatment options. This was really written in legislation. It is vital that they know every option that is available to them. However, food for thought in general, and again, that is one of the boundaries of decision-making, is not every patient wants to participate, depending on their own comfort, often driven by their own culture and background. Some patients may not feel comfortable being part of the decision-making process. And it is important to respect this too. Is decision-making a great tool? Absolutely. But there are limitations to this as well. So the second component, again, is help. So it's all centered around helping to explore and compare different treatment options or different plans of care, really, different ways of treating the patient. So what is really important here is an unbiased discussion about the benefits and risks of each option. And I'm really underlining the word unbiased here because we don't want this to be driven by the physician's preferences. It is really meant for providing what is known, what all the bare facts are, and really having an information exchange here. Now, again, a little bit of food for thought is that no treatment or no change to the current plan of care can be an option too. Sometimes people do not want to receive care. Sometimes people are happy with the plan of care that they are currently on, and they do not want to necessarily change this. So, for example, in a bleeding disorder world, if somebody is on a treatment product that is working great for them, they might not want to change that. No treatment options might also be pertinent. We often see this in cancer care, where patients might want to choose to forgo any treatment in that very moment. And that needs to be an acceptable choice as well by the patient. Again, that is one of the boundaries of shared decision-making. Now, what is very helpful in this moment, in the moment of help, is to utilize some shared decision-making tools. And those tools are really there to provide information to the patient and guide them through the process, but really delineating the different choices and the pros and cons and the risks and benefits of them all. So giving a little bit of food for thought here. Now, the next one in the shared approach is assess. And here it's really about assessing the values and the preferences of the patient. So it's the opportunity for the patient to really share what matters most to them. So if you are involved in a shared decision-making process and you want to be sure that your voice as a patient is heard, this is your opportunity to really share what matters to you. What are the goals for your treatment? What would you like to achieve? What does quality of life really look to you? And what are the different steps that you think you could take to that? It is very important for the patient to feel empowered that they have the capability of sharing their values and preferences, and that it actually matters, that it is an important component of reaching a decision. So it's important, again, from a provider perspective, to encourage the patient to talk about what really matters to them. Now, a little bit of food for thought is this is a great opportunity for family members and friends. They can sometimes be helpful, sometimes not so much, but there are many instances where they might be helpful of the patient focusing on what matters to them. Often decision coaches can be very helpful in this moment too. They are there for the patient, and they're really there for the patient to help them identify what their preferred goals are. Now, the next component in our share approach is reaching a decision. Again, since we are talking about shared decision making, reaching a decision will include the patient and the physician. It is not one or the other. They are really coming together. They are bringing all of their information and their background and their knowledge together, and they reach a decision together as partners. So they will really then decide on what the best plan of care is. Important component of reaching a decision too is not only to deciding what the best plan of care is, but simultaneously also then scheduling all of the follow-up and really making sure that there's a follow-through with the plan of care that was established. Again, a little bit of food for thought is that some patients might actually need some additional time to think about their options. So you might be in a clinical visit and it might be a great conversation, and then you get to the end of the conversation and you want to reach a decision, but maybe the patient is not ready to make that decision, and we need to accept that. At the same time, if you're a patient out there, feel free in this moment to speak up and be like, you know what? I'm not so sure about this. I would really love to talk to my family about this. Or, this is great information. I would like to think about this a little bit more, or I would like to do some get a second opinion as well. And that's the other point of food for thought. It is completely okay for a patient to seek out a second opinion. And no, if you are a patient out there, if you're a consumer, it is always okay to seek a second opinion. At the end of the day, though, you want to make a decision, and you want to make a decision that is right for the patient, that is right and in alignment with all of their values and preferences, but also meets the medical needs as well. So again, you're reaching a decision as partners. Now, the last step in this entire share approach is evaluate, and it's about evaluating the decision that you have made. So by now, you've gone through the entire share experience and you have come to a decision, and that decision and that plan of care that was decided upon was put into motion. It is time to reassess. Now, you want to assess the outcomes of the decision, and you also want to make sure that there is a positive impact on the patients and on their health outcomes. So a little bit of food of thought from here. So it is not, when you're evaluating this, all about, well, did they get better? Did they improve? But it's also about the psychosocial aspects as well. Are they happy with that decision? Does that decision work into their lifestyle? Are they able to integrate this? Are they able to follow up? Are there other hurdles or barriers? So it goes beyond of just the outcomes, like did the symptom disappear? Did they improve health-wise? It's really a whole person evaluation of whether or not this decision was right for the patient. And it is okay to say it was not. And it is okay to make changes to the plan of care based on the results of that evaluation. It is okay to change your mind. It is okay to then really work on the issues. So as a patient, I hope at this stage you feel empowered to speak up and say, you know what, this sounded like a good plan, but this and this and this is not working for me. Can we make a change to this? And at the same time, as the healthcare provider, we really want to embrace that and then really see how we can maybe refine the plan or make some quick little adjustments throughout. This is part of the shared decision making too. It's that continuous discussion with the patient, really making sure that the decision is still working, or the treatment plan that we decided upon is still working as well. So why does all of this matter? Why are we talking so much about shared decision-making and patient centricity? And of course, I've told you before, it's not a new topic. It's getting a little bit of a lift right now, but it is not completely new. And many people might say like, yeah, I'm doing all of this. This is old material. I've done this for years. This is my standard of care. But funny as it is, the perceptions are often different. So what we have found in research, in general research outside of the bleeding disorder world, which was also confirmed by some studies within, is that patients and healthcare providers often differ in their experience, perceptions, and beliefs regarding shared decision-making. So what a healthcare provider might think they're doing a fabulous, amazing job of integrating shared decision-making process into their day-to-day practice, but the patient might see this completely different. They might have a completely different viewpoint on this. And there's quite a bit of discrepancy throughout. So within the bleeding disorder world, there was this neat little project that was focused on shared decision-making, and it was a little bit of a pilot study to really educate people more on it, and simultaneously to tap a little bit more into those different perceptions and experiences. So this was really with people who have bleeding disorders, as well as healthcare providers who work in the HTC setting. And what they found when they evaluated them and when they surveyed them is that there was quite a bit of a discrepancy between the frequency of shared decision-making engagements. So while the healthcare providers thought that clinically they are most of the time really employing a shared decision-making approach, the patients had a very different view of that and didn't really feel integrated. A lot of this had to do with patients not feeling that their goals and values and preferences were ever really discussed, that healthcare providers didn't really specifically ask them about this. At the same time, they would have been able to share them, but there were no specific questions asked to the patients. So at the same time, they didn't really discuss what specific treatment goals a patient might have or what quality of life actually looks for them. While the healthcare providers, again, assumed that they had discussed this with the patient perception was very different, that they were never really able to share a lot of their treatment-related goals and what quality of life really means to them. There was also the discrepancy of understanding and fully conceptualizing different treatment options, risks, and benefits. While a lot of people believed they had shared them frequently, that was not necessarily reflected in the patient experience. And then also an assessment towards the treatment goals, that was often lacking. So that evaluation component, like actually, is our decision meeting the goals of the patient? Are we moving towards a good direction, or do we need to make any adjustments? So one of the interesting aspects that was in this little pilot work done as well was that they actually queried really the healthcare providers as well as the patients about some of the preference or some of the treatment related concerns they might have, especially when it came to changing treatments or changing products or treatment plans or approaches. And while a lot of the healthcare providers believe that a lot of the worry from the patient side was more centered around the change of product, side effects, and whether or not the product will work as well, the patient's concerns were more centered around access and affordability, whether or not they would have access to his treatment, whether or not they could actually afford it, or if their insurance would be troublesome, if they would be required to pay a lot more out of pocket. So a lot of their concerns were really centered around payment and being able to pay for their treatment options. So this was a neat little pilot project within the bleeding disorders world that I wanted to highlight, because it undermines or underpins a little bit that thought process that while we very often believe we're doing a wonderful job with shared decision making and we are integrating it into our day-to-day practice, there is a little bit of room for improvement, and there's a lot more education that needs to be done, a lot more of implementation, and really being able to pull this through. So moving on forward, when we're looking into shared decision-making and specifically in the bleeding disorder world, we're looking a little bit more towards the research component of it. Our research is actually very limited. There's only a very few articles that are focused specifically on shared decision-making. And the current literature really centers shared decision-making around treatment choices. So choosing between different treatment options, between those treatments that are using a more traditional IV infusion, extended half-lives, and then more of a subcutaneous option, as well as gene therapy. And I think this is really why we're getting such a big revival, a lot more talk about shared decision making. It's really the prospects of gene therapy becoming a reality and having to make a decision about a treatment that is impacting the lives of people with bleeding disorders significantly. So a lot of the conversation that is going on in current literature is really centered around gene therapy and how shared decision making could really aid in the patients, and what the needs and educational goals for patients as well as healthcare providers might be that would really aid in a shared decision making process. There's very minimal literature on any sort of interventions and shared decision-making tool development. So we're talking a lot about the concepts. There's very minimal programs where we actually had some sort of an intervention to improve shared decision-making and really analyzing the outcomes of that with real-life data. And then also the development of shared decision-making tools, which I outlined earlier, are really helpful when we are helping our patient to explore risks and benefits and really gaining information in the different choices, but then also that will help guide the patient through the conversation of a shared decision-making approach. So we don't have a lot of literature in the bleeding disorders world there, and I'm hopeful that much, much more will come in the near future. So lots of room for improvement and future projects. So in conclusion of all of this, so really summarizing patient centricity, shared decision-making, and where we might have some opportunities in the future. So HTCs are very well situated in providing patient-centered care. They have a wonderful integrated care model with an interdisciplinary team, and it's essential that we maintain these so they can provide the appropriate care to people with bleeding disorders. We also know that shared decision-making is an essential component to achieving patient centricity. It is one of those big foundational blocks there. Now, the management of ongoing care of bleeding disorders, so people with bleeding disorders, is an excellent opportunity to initiate shared decision-making. We have wonderful opportunities where we can really incorporate the share approach or other models to allow for shared decision-making to occur in the clinical setting. And again, about research, while research is very limited, this also provides us an excellent opportunity for future meaningful projects that put, again, the patient in the center. And I would love to see some more development of tools, great programs of really involving the patient and really improving overall quality of care. So lots of opportunities here. So with this, I would like to thank NHF for inviting me to talk about shared decision-making, really a topic that's very dear to my heart. And I would be happy to take any questions that you might actually have.
That was great. Thank you. Let me see real quick. I'm going to share my screen. We're all set. That was wonderful and super informative. If anyone has any additional questions, please feel free to throw them in the Q&A. But I do have just a few for you. So this was very helpful and informative. If someone was trying to give simple definitions of shared decision and patient centricity, how would you define them?
So a simple definition. So let's see, that put me on the spot here. So,
I'm sorry.
No, it's fine. So shared decision-making truly is a two-way decision-making process that involves both the patient and the healthcare provider. Does that work? And
Yeah.
then patient centricity really allows for treating the patient as a whole, or placing the patient in the center of care and allowing a wholehearted treatment.
I love
from
that.
a biopsychosocial lens. Trying to put this in a one sentence short definition.
No, that was great. Thank you so much. And one
Sure.
more for you. So what is NHF doing to support shared decision-making and or patient centricity for community members?
Yeah, absolutely. That is a wonderful question. So let me start out with the shared decision making component. So one of the shared decision making components we are currently working on is the development of shared decision making tools. So some of these tools will be geared towards VWD. So as many of you know, we had these wonderful, amazing VWD guidelines that were published in 2021. So they have been out for over a year. So within these guidelines, there are several recommendations that would actually allow for a wonderful shared decision-making approach. So we are in the process of developing shared decision-making tools for exactly those recommendations that can be used clinically. We are following a rigorous process for this, and we're hoping that those will come out rather soon. So we're developing those. We are also in the beginning stages of really partnering with other organizations such as WFH on developing shared decision-making tools for gene therapy. So this is a process that is starting as well. So we're really focused on doing that. And then in general, we're providing a lot of education and information about different options, and it's coming from an unbiased perspective. So we're really trying to be broadband in our educational initiative. There's lots happening on the innovative and future therapies side, where they will be developing a lot more information on different treatment components as well. So stay tuned for all of those. But it's really, that's our focus when it comes to shared decision making. So a lot of different pieces are in motion there. And then as far as patient centricity goes, so we are working right now on really truly defining patient centricity and what that would mean for different stakeholders and different entities. Stay tuned, coming soon as well. And then we are also supporting the HCC network. So that is something from an advocacy a component that we are always striving to, so that we are continuing to have our hemophilia treatment centers. As I said before, those are really well situated in providing integrated care models. So it is important that we are sustaining our hemophilia treatment centers, and at the same time that we are increasing the access to these, that people with bleeding disorders will have access to their hemophilia treatment centers, and will be able to really tap into the expertise of people that are there. So NHF is really thriving towards supporting access and for people with bleeding disorders.
Wonderful. So one more for you. Are those tools designed for community and provider education on shared decision making?
Yes, they are.
Great. Wonderful. Okay. Well, I just want to thank you one more time, Lena, for taking the time to join us this afternoon. We appreciate you and your expertise so much. And I'd like to thank every one of you for joining us virtually and watching. Please note that this recorded webinar will be available on Friday, April 1st at hemophilia.org under the events tab with all of our archived webinars. Also available in the events tab is our upcoming schedule for our weekly Wednesday webinar series. Thank you again for joining us this afternoon. Have a wonderful week, and we will see you next week. Bye, everyone.
Thank you so much, everyone. Thank you for inviting me too.
Yes, thank